So today we're going to talk about some disorders of the ovary and the management of adnexal masses. So an adnexal mass, right? So this is something that you feel. It's very difficult to ascertain whether you're feeling something on the ovary, the fallopian tube, or that surrounding tissue. So basically, anything in that area that you're feeling to one side or the other on your bimanual exam that is distinctly not uterine is called an adnexal mass until proven, until given a definitive diagnosis. I'm actually not sure if this is a good link, but I'll make sure it is because that's a good video. So, just a refresher about the anatomy of the adnexa, right? So, everything out here is considered the adnexa from the isthmus of the fallopian tube out to the fiambrae. So, anything that you feel in this area is an adnexal mass. So it's possible that you can even feel something in the descending colon there and not be able to rule out without imaging that it is, not the adnexa. But anything over in this area is considered adnexal. Adnexal masses are pretty much divided into these categories. You can have a mass of the ovary. Remember that mass does not always indicate something bad or negative or malignant. That just means that there's something there that shouldn't necessarily be there. So there are functional cysts. You can have symptoms of endometriosis, a neoplasm, something benign, malignant. Those are cystic. So something that you feel that may be fluctuant, mobile, and we'll discuss in just a few minutes about how to determine if something is functional, non-functional, simple or complex as far as cystic structures. In the fallopian tube, there are a couple of cystic and solid structures there. Always your biggest concerns are ectopic pregnancy and a tubo-ovarian abscess, which we'll talk about as well. Uterus is, you can have an intrauterine pregnancy that actually is you're unable to necessarily tell if that is just uterine enlargement, if you have an ectopic pregnancy, if the patient could have a fibroid uterus that maybe has a pedunculated fibroid over on this side that you're feeling, and then bowel issues like we talked about. Sorry, this slide is kind of busy, but cysts. So again, we're back to cystic structures of the ovary or the adnexa are divided into functional and non-functional. Basically, the key to remembering what those are functional cysts are related to hormones, right? So they occur resulting from the normal menstrual cycle. We all know that follicular cysts are normal, right? So the ovaries create those little follicles each month and before ovulation, and then those should go away. Then the corpus luteum takes over, hangs out as a cyst until the body, until pregnancy does not occur, and then it should resolve on its own. So again, either one of these can hang out and continue to grow and become an enlarged cyst that becomes uncomfortable. But again, they are functional because they are related to the normal menstrual cycle. Either one of these cysts can become, or these types of cysts can become pretty large and very painful. Um, we'll talk a little bit more later, but a cyst can rupture, and it's basically like a water balloon. Rupture sounds like a horrible word, right? Because we're thinking of the appendix rupturing, any other thing that ruptures. But it basically is that fluid, like a water balloon, just gets so full that it will, pop open the little water balloon cavity of the cyst. Patients typically feel suddenly much better when that happens. And in patients that I'm assessing in the office, and I know that they have a large ovarian cyst that's uncomfortable, but it's not, large enough that they require surgery, emergently or anything like that. I do explain to them that that's what will happen if it's going to rupture. Typically they have, and the classic story of someone who comes in from the ER telling you a story of a cyst that ruptured that, they may not know what happened or what their explanation is. But the classic story is they had horrible, sudden abdominal or pelvic pain, right? So maybe they were crampy, uncomfortable for a while, maybe even a couple days, and then it got suddenly worse. It's horrible pain. And about the time they get to the emergency room or are ready to go to the ED, the pain is better. So once that cyst pops or ruptures, they're still uncomfortable because of the free fluid out in the pelvis. But that severe pain is gone and they actually feel much better. And when you scan them, if you do a transvaginal ultrasound, you will see probably, the look of a cyst that has ruptured, a free or an empty little sac there, and then fluid out in the pelvis. And you'd be surprised at how small of an amount of fluid in the pelvis can make someone uncomfortable. Um, and I always explain that, a cyst, a mass, anything that's there that, even though it sounds small, right, 2 or 3 centimeters, it is a space occupying item that isn't normally there. So it is, putting some pressure on things, putting pressure on the other pelvic organs there, which we all know are, fairly sensitive as well. So the size of the cyst, the location, sometimes does not necessarily correspond with the numbers or the images that you have to look at. Okay, so non-functional cysts are, they can just grow or happen randomly. So they are not a result of the menstrual cycle, right? And so they are not under any hormonal influence. And we will go through each of these individually. There are a group of benign non-functional cysts, and there are a group of pathologic or potentially cancerous lesions. Masses. This is just a visual of what we basically just talked about. These are functional, right? So you really only have 2 functional, so that's pretty easy to remember. The corpus luteum or luteal cyst or follicular cyst. Any of these others are non-functional, right? Remember, they are not a result of hormonal fluctuations throughout the menstrual cycle. The most common type of cyst is a follicular cyst. So that's formed during that first half. So they're during the follicular phase. And it's basically just a dominant follicle that doesn't ovulate. So they, after menopause or before menarche, those would be very rare, right? So if someone is not ovulating, yet that follicular cyst is going to be very rare. Most are pretty small. They can be up to 6 centimeters. and still be, not worrisome. And they usually go away on their own. And this is a video here regarding follicular cysts. Symptoms, they are often asymptomatic. You may feel them on a bimanual exam because they are hormonally influenced. A young woman or woman may see changes in her menstrual cycle for a couple of months. That cyst is likely going to rupture, and they have that acute pain that we talked about. A very large cyst, or depending on where it is, can actually, those are the symptoms that it can cause: pressure, fullness, ache. That pain may radiate down to the lower back or down the legs. A large cyst can actually do, you can have what we call a torsion, which basically means the weight of that cyst on the ovary twists either the fallopian tube or the weight or the ovary upon itself, cutting off blood flow, which is very painful in an emergency situation. So, again, it's typically 5 centimeters or less, cystic to firm, mobile, sometimes tender, and typically unilateral. Another functional cyst is the corpus luteum. So that typically will start in that second half, right, of the menstrual cycle. Another video here about corpus luteal cysts. As it degenerates, there may be some bleeding into the cyst cavity that the sonographer will be able to tell you about as well. Again, not typically symptomatic. Cycle irregularities, acute pain with rupture, torsion. So pretty much the same physical findings. Now we're going to start talking about, don't get grossed out, we're going to start talking about non-functional ovarian cysts, or, adnexal masses. This is called a dermoid. You're also going to hear it. It's a teratoma, benign cystic teratoma. It is one of the most common ovarian neoplasms. And remember, neoplasm does not mean cancer. It is a germ cell tumor. So think back about what we learned about germ cells, right? And they can divide and grow into a certain group of tissue. So these you'll see during the reproductive ages of a woman. It is well differentiated tissue from all 3 germ layers. So they will have hair and skin and teeth and other types of tissue there. So everyone always gets really excited to see these. Typically, they need to come out due to the size, and they are firm and they can become uncomfortable. They can get up to like 10 centimeters. Sometimes they are unilateral, but about 10 to 15% of the time they are bilateral. And that is just something that happens in development in utero. And again, there's a video here about dermoids. If they get large, they can cause pressure. They're very firm and often anterior to the uterus because they are a true ovarian mass. A lot of times you just watch them over time, and if a patient becomes uncomfortable or if it continues to grow, they will do a laparoscopy to remove that cyst. Another non-functional cyst is hemorrhagic, which means that there is a cyst there, that a small vessel from the ovary has bled into the sac of that ovary. So that blood there may be within the cyst wall, that was a new word, or leak out into the pelvis. That leaking of fluid can certainly, leaking of blood out into the pelvis can cause significant pain. These also can become big and rupture. Those are typically ones that they will go away on their own unless they're really large. and you just watch them unless the patient is significantly uncomfortable. So endometriosis is one thing that we will be discussing in this module. So hopefully this all kind of falls into place. Endometriosis is essentially where the endometrial cells, so the endometrial lining is outside of the uterus. And you can see this kind of example of endometriosis, with cells outside of the uterus. An endometrioma is basically a cystic lesion stemming from those cells that are out in the pelvis. When endometriosis implants into the pelvis, it can implant anywhere, and then it just grows and reproduces and bleeds and sheds just like the endometrial lining does. So about 40%, a large percent of women with endometriosis do develop this type of cyst, endometrioma. So basically that is where endometrial cells have implanted out onto the ovary and created a cyst where it has bled and shed and bled and shed and bled and shed on itself over and over and over again. Okay. Well, again, more about on endometriosis, but in someone with endometrioma and endometriosis and trying to get pregnant, this can obviously affect the ovary. That being there can decrease the ovarian reserve of follicles and oocytes because of its, basic, it's making the ovary kind of dysfunctional is a good way to think about that. Etiology of endometrioma, we kind of talked about that. They do have a very specific appearance on ultrasound, but a definitive diagnosis by surgical visualization. These are often called chocolate cysts. If you've ever seen one in the OR, you know exactly why. When I don't know if I have a video here. I'll try to find one if I don't have one. When the cyst is, we really try not to disturb the lining of the cyst. If at all possible, the surgeon tries not to, because unfortunately it does make a big mess and also can, then additionally seed endometriosis out into the pelvis. But when those are ruptured in when they are popped during surgery, it's just brown. It looks like melted chocolate, but not in a good way. So that gets all out into the pelvis, which requires a lot of irrigation, and because we don't want to leave any of that there. So they try to withdraw those or take it, remove it complete, removing the entire cyst capsule. So in endometriosis, we'll talk about the management of that, but one of those things is a GnRH agonist, so Depolupron. Sometimes it is given for endometriosis. It may decrease the size of an endometrioma, but it doesn't do anything about the pain. So typically the management is surgical for this. It does have a small risk of increasing epithelial ovarian cancer, but again, that's very small. Okay, another non-functional adnexal mass is a para-ovarian cyst, and these are about 5 to 20%. And you can see that they're little fluid-filled sacs. They are epithelial-lined cysts out in the adnexa. They can originate in the broad ligament there. So you'll also hear them called paratubal cysts. Most of them are asymptomatic. If they are going to be symptomatic, they are painful. Um, they're frequently diagnosed as an ovarian cyst just because of their location and proximity to the ovary, but they typically just go away on their own. They don't respond to hormones, right? Remember, anything that's non-functional is not going to respond to hormones. If it's difficult to differentiate, or it's a fertility issue, then they are removed surgically. So, in a patient with subfertility or infertility, that there is a potential, there's thought about that's disrupting the lining, the epithelial lining of the tube, maybe causing some inflammation or disruption in the function of the tube. So those are typically taken out when found there. Another non-functional cyst is a cystadenoma. Common, benign. They grow from the surface of the ovary, but they're not associated with ovulation. So that's why it's still a non-functional. Most of them are serous and mucinogist. There are some endometrioid and clear cell cystadenomas, but that is rare, and those can obviously develop into cancer, those clear cells. They're very, very rare, and there are few reports of them at all. When they're large, similar symptoms as everything else. This is letting you know what benign imaging looks like. A transvaginal ultrasound, a vaginal scan of an ultrasound is always, always, always the best picture of the uterus and ovaries as a diagnostic tool. Sometimes, rarely, is something additional like an MRI recommended. So if you're ever asked a question, what is your next step in management in something like this? Ultrasound is typically your first step, right? So that's why a pelvic ultrasound is always the best step. I'll have women who have been to the ER and they had an MRI or a CT scan. Well, I just have to do an ultrasound because I don't really know what that CT scan or MRI was seeing, So, but that's okay. That's not what the ED does. I'm not hating on anybody. I don't want anybody coming in with chest pain to my office either. So they usually go away on their own, and recurrence is not common. These are what they look like, and you can see how large they get and what the drainage from that looks like. This is in a 31-year-old patient, and this is saying that it's 7 centimeters and it didn't change in 3 years. So I can imagine that would be pretty uncomfortable, but I'm glad she finally got it out. So your differential diagnoses for any adnexal mass, right, are always pregnancy. Pregnancy is on the top of your list a lot of time, right? So if you do have a pregnancy, ectopic pregnancy. So remember, even if you have a patient with a history of sterilization or an IUD, there can still be a pregnancy out in that tube. So don't dismiss a pelvic mass in someone who is, using reliable birth control. So we're going from most common kind of to least common, depending on the patient. So pregnancy, ectopic pregnancy, ovarian torsion, those are your tubo-ovarian abscess. Those are, this could be a gynecologic emergency. I need to do something right now. So that's also a question that you will be asked in exams, and something you obviously want to know when you're seeing patients. So pregnancy, you find an adnexal mass, no matter the age of the patient at all, right? So you find it there, you need an ultrasound to give you more information. If you had a positive pregnancy test, then we're looking at E, right, to rule out ectopic pregnancy. The sonographer is going to look at the fallopian tubes anyway, and even if the patient maybe hasn't missed a period, a urine pregnancy test is pretty sensitive. That if it's high enough to, if a pregnancy is high enough to put off, any amount of HCG, really, it's going to be detected. In a postmenopausal woman with a new adnexal mass, you should get a CA125. So remember, CA125 is just a whole big discussion and argument sometimes. CA125 is not screening, nor is it diagnostic for anything. Okay, so if this woman did not have a mass, we are not doing a CA125. If she has a mass and an elevated CA125, that is not diagnostic for cancer. They're just pieces to the puzzle, right? So this woman still needs a transvaginal ultrasound. So then we start looking at, and this is someone you've got postmenopausal, positive CA125, and an abnormal ultrasound. She's going to the physician. This is now out of your scope of practice. But she, most likely will just have surgery. But if the CA125 is elevated and there's a complex cyst there, sign of ascites, anything like that that's going to be abnormal, typically these women are just sent to GYN oncology immediately. Because if there is something, if you do have an ovarian or an adnexal cancer there, it should be diagnosed, managed, immediately. If you think there's a dermoid there, that is when an MRI may be helpful because, right, that is a solid tissue there. Ultrasounds are pretty good about being diagnostic for dermoid or highly suggestive of dermoid, but if you're ever just not sure, that would be the time you could do an MRI. In the reproductive years, if you've got a cyst less than 10 centimeters, it is simple, and the patient you can keep her comfortable with NSAIDs and other first-line management. You could look at it again after her next period and just continue to watch it resolve over the next few menstrual cycles. A lot of practitioners will put a patient on a birth control pill, a combined hormonal contraceptive, in hopes to make it go away faster. It does not work that way. It doesn't help with reduction, right? Because remember, the hormonal fluctuation that caused it has already happened. So you can't undo what has already happened. In someone who has them frequently, right, or has cysts often, which can happen, in adolescence as that HPO axis matures. It is a good way to prevent recurrence. So to keep someone from having frequent cysts that get large and uncomfortable. But it does not help with the immediate problem, the current problem. If you have a large mass, if something looks solid, if it's complex, if there are concerning symptoms, right? So pain that doesn't go away, she has nausea, vomiting, she just doesn't feel right. Anything that just does not fit the clinical picture that you're expecting, or if it persists more than 3 months, she just needs to see the physician anyway for that. In postmenopause, if there's a mass there and it's less than 10 centimeters, confirmed by ultrasound as simple, and there are no risk factors or symptoms for ovarian cancer. We haven't talked about ovarian cancer as of yet. We will. The trickiest thing about ovarian cancer is that symptoms are so vague. So vague. So someone can have abdominal pain, or they get full faster than they used to. They feel bloaty. The symptoms are so vague, and that's one of the reasons that ovarian cancer is so deadly, is because often the symptoms are not only not recognized by healthcare providers, but not recognized by patients as necessarily abnormal, right? So if the CA125 that you drew when you found the mass is less than 35, and the mass is less than 10 centimeters, confirmed as a simple cyst, you can follow that with ultrasound. Personally, I've never done that. If I have a postmenopausal patient with an ovarian mass, whether there is an elevated CA125 or not, she sees my physician. These are reasons that you would definitely refer. So this is going to depend on, your experience, your comfort level, your practice area, and your facility or your physician guidelines. In postmenopausal, if you think that there's a dermoid there, you're going to refer them. It says if it does not resolve spontaneously, but I've never seen one resolve spontaneously. Okay, so management basics. These are just some terms that I want to make sure that everyone understands, because these are going to be used a lot as we talk about gynecology. So expectant management is when what you're seeing is not suspicious for malignancy and there are no indications for surgery and no further follow-up is needed, right? So you're just going to say expectant management, and then, tell the patient when to call you. If you have severe pain, abnormal periods, if something changes, gets worse, new symptoms, then you're going to call me, right? Surveillance is an option if you don't think it's, the suspicion for malignancy is very, very low, but it hasn't been completely excluded. And maybe she's still having pain, discomfort. What you've tried isn't making her feel better. We're going to call that surveillance, right? So you're either going to do close surveillance, long-term surveillance, short-term surveillance, whatever is recommended based on, or, whatever her symptoms and clinical picture warrant. Surgery is recommended when the patient has persistent pain or symptoms that we can't fix with medication or time, or if there's any suspicion or high risk of malignancy. So, like I said before, a postmenopausal woman with a new ovarian mass and symptoms, I'm referring her. She needs a surgical consult at minimum. Okay, so now we're to simple versus complex, right? So you can have a functional, simple, or complex, or you can have a non-functional, simple, or complex. They typically fall into one category, though. Simple are fluid filled. They can be filled with different kinds of fluids, so keep that in mind. It can be blood, thick mucus, thin, watery fluid. They're almost always benign, no matter how big they get. So even if you have an 11 centimeter simple cyst, it is almost always benign. Complex cysts are solid or irregular. They can have septations, which means, you have a cystic area, but it has little cysts within it. So you can see dividing membranes, and those are called septations. An ovarian torsion, we kind of mentioned that earlier. It is uncommon, but when it happens, it's very bad. Spontaneous twisting of the ovary on its mesentery, right? So you remember where the mesentery there out in the abdomen, that blood flow to the adnexa. So that enlargement or heaviness of the ovary twists on itself or twists that mesentery, and basically an ischemic event happens, horrible pain. The It's very tender, very painful. It needs This patient needs surgery immediately to resolve that. Sometimes they can untwist the torsion, and put a small stitch there to maintain, remove the cyst, or with empty the cyst. If they can get blood flow to return to the mesentery, just a simple untwist. I'm sure there's a better word for that, of the adnexa can return this to normal. But some women do lose the ovary and fallopian tube, as well as its mesentery blood flow at surgery. So the risk of torsion is higher during pregnancy or after ovulation induction. So we think about, that corpus luteum cyst can get pretty big during the first trimester of pregnancy. So that's why when you have a large one on your first that dating ultrasound, you're going to keep an eye on. And it's more common for several reasons. They can be bigger. Everything is loose. It could be of the progesterone relaxation. And then when we are inducing ovulation, like in a patient with infertility, you can get hyperstimulation, where we get very large or too many follicles there, making that ovary very heavy. This is what a torsion can look like. So you see that's twisted and very ischemic there. It is very painful, and it can come and go and then get suddenly bad, or it can just come out of nowhere. With nausea and vomiting, these women don't feel well at all. So it's very tricky to ascertain that difference in symptoms between an ovarian torsion and an ovarian rupture. An ovarian rupture, pain goes away, right? They don't have associated symptoms either. They feel bad, they have a horrible onset of pain, and then they feel better. With the torsion, the pain just keeps getting worse and worse and worse and does not resolve, and they don't feel well. There's the word detorsion. There are those surgical options there. Some other adnexal masses. Hydrosalpinx is the fallopian tube is blocked with watery fluid. This is often due to scar tissue. So history of PID, other STIs, endometriosis, or previous pelvic surgery. Sometimes asymptomatic. Some of these ladies have frequent pain and lots of watery discharge, because that watery fluid is blocked in the fallopian tube. It can impact fertility, which is why we are looking at women with fertility. These can be repaired, or they need to be removed. So once that is, diagnosed, then the gynecologist is going to decide what to do with that particular patient. A tubo-ovarian abscess is exactly what it sounds like. There's an abscess somewhere, it's either involving the tube, ovaries, and the adnexa there. Again, another consequence of PID, diverticulitis, right? So the bowel issues, or pelvic cancer. These patients present with pain, fever, nausea, leukocytosis, and an adnexal mass. So, right, she has an abscess, she's infected, she's going to have fever, and she's going to have abnormal CBC. This is a link to up-to-date reference for specific abscess management for antibiotics. A ruptured ovarian abscess is considered an emergency. So think about a ruptured appendix and all of that purulent bacterial fluid in the abdomen. Same kind of thought process here. So we don't want all of that in the pelvis, or you're going to get peritonitis. So you're really going to see this in the office. This is someone that's going to present to the ED, but you should know this is often a question about what is a true gynecology emergency, and this is definitely one. So we have acute pelvic pain and chronic pelvic pain. Ectopic pregnancy we'll kind of cover again at one point, and it certainly is a cause of acute pelvic pain and is always on your differential diagnosis list for acute pelvic pain. This is a video for you for acute pelvic pain. And there are your references. So, the definition of anything acute and chronic for pelvic pain is pelvic pain is it's kind of like, you hear stories of the on TV shows or whatever. Abdominal pain is the nightmare of the surgeon or the primary physician. Pelvic pain, you will see a lot of pelvic pain. And you hope that it's something simple, such as an ovarian cyst or constipation, or something very easily managed. But unfortunately, you will have issues like chronic pelvic pain of unknown etiology. Chronic pelvic pain of scar tissue, endometriosis, PID, sequelae. So, pelvic pain is something that you will see a lot in practice, and we will cover all of that more specifically. But that is your ovarian adnexal mass lecture. Let me know if you have questions.